It's fantastic to see so many people joining us today at our second meeting. I'm so delighted to that we've got such wonderful patient support from across the region. And just to sort of reiterate that we're delighted that we've got William here supporting us as the chair for the patient partnership group and being that lead to go to the Thames Valley Cancer Board and be the patient voice to make sure there's the appropriate check and challenge in what we're doing and how we're delivering cancer services across the Alliance. With any transformation work that we do, we want to make sure that the patient voice is at the heart of what we're doing, that service redesign really is meeting patients' needs and not what we as clinicians think may be required. And so there is a lot of work around co-production, but I'll allow William to talk a little bit more about that, but your voice is really important to us. And there's many ways that you can be involved and support us with doing that. But I'll allow others to talk about that a little bit more as we go on. What I just wanted to share is to sort of update a little bit on the key priorities for the Cancer Alliance. So we have 4 priorities. As William was saying, there's so much that we could be working on in the cancer arena. But we do want to try to sort of bring our work down into 4 key streams of work so we can deliver on each of those aspects. Excuse me. So the first one is around sustainable operational performance. So Victoria is our lead for that, and we actually have we've been developing what we call a cancer dashboard that the Alliance can use and each of the trusts can use. So that's looking at the cancer performance wait time data, which is submitted on a monthly basis, but it's in arrears that we submit that because the data has to be validated. But that data, and then we're trying to have a live stream set of data coming through from each of the trusts, which help us see where perhaps cancer performance is going off. So when I talk about cancer performance, I'm talking about things like 2-week wait. We have a new standard now called the faster diagnosis standard, which is where any patient who has been referred in on a 2-week wait should have a communication of a cancer diagnosis within 28 days of that referral. And by that, we also mean where you don't have a cancer diagnosis, hopefully, that those people are also being informed in a timely way, because there's nothing worse than waiting on the line, not sure if you have a cancer diagnosis and no one is coming back to you to say, actually, those results show that things are clear. And then there's the 62-day performance target. And then we're working with trust to make sure that we're understanding where patients perhaps aren't being treated within 62 days. What are the delays in those pathways? What can we do as a system to help support? So there's regular meetings with the trust to support them with their cancer performance. That's a very brief overview of operational performance. Then we have what we call rapid diagnostic services. So this is a new national initiative where we're trying to support people being diagnosed to meet that faster diagnosis standard by day 28. Within the Alliance, we're focusing on 2 tumour sites that we feel could benefit from the support. One is the lung pathway and the other is the colorectal pathway. So all of the trusts are involved in delivering the lung RDS, rapid diagnostic service. And then 2 trusts are supporting the colorectal pathway. I know Patrick is going to talk a little bit further about that. He's our patient rep to support that work and to ensure again that that patient voice is at the heart of this transformation work that's happening within the Alliance. When we look at the addressing the shortfall in treatments, this is where we're working to support the national cancer initiatives of early diagnosis. So where there may be blood in the urine that you may see on the sort of TV screens about supporting urological cancers or around that cough that persists after 3 weeks, trying to ensure that patients and staff are aware of those warning signs and how we can improve people attending. We know through the Alliance it's been challenging, through the pandemic, it's been challenging for primary care, but for patients to access services and to share their signs of that they may be concerned about. But we do want to encourage that voice of stepping forward if you have concerning symptoms, and not to think the NHS is under pressure. It is important to attend and be seen and referred as appropriate. There's other innovative things that are going on within the cancer world. You may have heard of these before, but we're involved in what we call the colon capsule endoscopy project. That's happening at the Great Western Hospital in Swindon, swallowing a small capsule or a pill that helps. It's a type of endoscopy treatment where they then they follow the pill via a camera. It transits over a 24-hour period, and then the films that are taken can be interpreted to see if there's any concerning symptoms. There's also GRAIL, which is a blood test, which is trying to identify cancer at an early stage for those patients being referred in on a 2-week wait. That's being supported by hospitals in Oxfordshire and some in Buckinghamshire and Reading, Berkshire. And then there's also what we call cytosponge, which is a particular type of test which is being done in Oxford to try and help with the diagnosis of upper GI cancers. And then finally, but not least, is the personalised care agenda, which is around supporting patients to live well with a cancer diagnosis. We know we have an ageing population, more people being diagnosed with cancer, unfortunately, many more lines of treatment. So many people are being supported, as you will be well aware, on their cancer journey. And so there's a lot of work that Hannah, who's on the call, who will be talking a little bit more about the work that's being done, is supporting that work stream. And Daffod on the call is also the patient rep to support that. But very briefly, the personal care agenda relates to end of treatment summaries, what we call holistic needs assessment. There is something called stratified follow-up or patient-initiated follow-up following breast, colorectal and urological cancers. And then we're also looking at possibly hematology and gynae cancers going forward to have, once you've completed treatment, being able to be discharged from the service, but easy access back into the system. But that needs appropriate support and structure to put that in place, and then work with primary care to do cancer care reviews as well. And there's various living well projects, living well events to support people going through that experience as well. And then other things to help support that is we're very aware that there's real pressures on the NHS in relation to workforce. And so we have a particular workforce stream, which is trying to look at the different healthcare professionals and how they can help support different elements of the cancer care pathway. That's from perhaps physician associate roles to advanced clinical professional roles, as well as our allied health professionals and others to support that. And then, as I said earlier, your voice in supporting any of this transformation work is really important to make sure that Thames Valley Cancer Alliance services are as what you would expect, and help improve that patient and family experience going through the cancer journey. I think I've probably said enough, Lisa and William, so I'll hand back to you unless there's any particular questions.
Okay, thank you, Linda. I think it's important just to put this in context. I mean, this isn't original. It's something which was brought to my attention by a young mental health service user with very kind of strong views on the whole thing of engagement as opposed to tokenism. And I think Lyndall's word about transformation, I think, is really important in this context, because I think there's still a kind of an approach often within the health service to be doing the things at the bottom of the ladder as opposed to getting towards the things at the top. And I mean, I think what's really important, is if we start off with that middle thing about doing for, I think it's important to recognise that engagement and consultation and informing, there's nothing wrong with that, but it's something that needs to be a starting point as opposed to an end point. So it's about how do we go beyond consultation to actually engage us as patients service users, carers, wider families in actually, first of all, being involved in the co-design of the services that meet our needs. How does that actually happen in practice? Can we just move on to the next slide? Okay, so what's true production mean? Again, you've got that little diagram on the right-hand side, where we've got this sort of, classic Venn thing about things overlapping, with co-production being the key thing in the middle, and all those other circles, contributing to it. And the final sentence there, service users are involved every step of the way. I think that's a critical aspiration and something we need to hold the NHS to account for. And I think it's up to us to make sure that we're going forward in this process, and as I said earlier, in a sense, to continually test out how are we performing against this? Are we getting there, or are we simply talking and not doing? And I think we need to get the balance right between talking and doing. I think that's really all I need to say about that at the moment. But if people obviously taking some notes here, I think we're going to be circulating the pack afterwards. Lisa, is that the case? So don't worry about taking detailed notes. You'll have the pack available. Okay, thanks very much then. I think that then takes us on to the next agenda item.
Lovely, thanks, William. Okay, so I'm just going to give you a little brief overview regarding the structure of our patient engagement as it stands within the Alliance at the moment. There are presently 21 groups internally within the Alliance where patient engagement is fundamental within the terms of reference of that group. Groups include our executive board, which obviously William is now a representative on, and our executive board provides direction and strategy, setting the priorities for the Alliance as detailed by Lyndall earlier on. Its membership is made up of senior leadership drawn from organisations and agencies across the Thames Valley, and it actually holds the Alliance to account regarding the local delivery of the National Cancer Strategy. Meetings are scheduled on a quarterly basis, with senior managers from our Alliance providing progress updates against the Alliance's programme of work. We then have our TVCA delivery group, so that is overseen by the board, and it's to deliver the ambitions of the Thames Valley Cancer Programme and provides clinical and operational leadership across the whole patient pathways of care. And the group endorses relevant national clinical guidelines, policies and processes, as well as overseeing risk management, escalating to the board when applicable for agreement on actions. We also have on the left-hand side there our clinical advisory groups, also known as CAGs. They work within their own specific specialist area to improve patient care through integrated cancer services. They agree and assess the Alliance standards, including guidelines and protocols that are not covered nationally by the mandated standards. They develop and maintain clinical protocols, as well as review operational deliveries of pathway of care between our providers, so our trusts within the Thames Valley. So we have, within the terms of reference for our CAGs, 2 patient representatives as a requirement. However, we do not have a full complement at the moment of patients on 8 of our CAGs. The 8 are highlighted in red on the left there. Some of our CAGs have actually re-evaluated whether or not it's appropriate to have 2 patient representatives on them. For example, our pharmaceutical CAG is very operational, so patient representation wouldn't actually be influential on this group. Our teenager and young adults CAG, they've taken a different approach with regards to incorporating patient involvement, and they've asked a spokesperson to represent the patient voice in the form of their Teenage Cancer Trust Youth Support Coordinator. who has various different sort of frequent and significant interactions with TYA patients, and therefore will be the kind of conduit to sit on that group. A similar approach is also being considered for our children's CAG. With regards to the Personalised Care Forum noted at the bottom, this drives forward the priorities around personalised care agenda and sharing best practice across Thames Valley, which Hannah will be sharing with you shortly further information on. And our RDS steering group drives forward the priorities around the rapid diagnostic service. So patient engagement across all activities within our internal alliances within our internal alliance groups does vary. This depends on discussions and obviously outcomes to be taken forward by each of those groups. The level of involvement is entirely down to what our patient representatives can offer. Obviously, the offering that they give is voluntary, and there are elements of expectations that are set out in the tools of the, when I say tools, sorry, terms of reference for those groups, but it's purely on a voluntary basis that we kind of take on board our patient representatives. Not all of our patients want to be involved in a working group or to attend meetings. They're happy to be involved in separate patient engagement activities, which is absolutely fine. So going forward, the aim of our PPG is to actually have oversight of all the patient activities across all of these different groups and forums, helping to take forward in particular areas of support or themes of concern our viewpoints to our executive board. So with regards to the external groups where patient engagement is undertaken, there are various elements or various groups that we sort of feed into and feed out from. Some already have a direct link in with our delivery group, but where there isn't a direct link, then the intention is that the PPG will be this key mechanism so that the wider patient voice is still brought into the alliance. It's important to ensure that patient experiences through engagement with our wider stakeholder networks, i.e. Healthwatch, community organisations, third sector organisations at a local level is incorporated onto the PPG to also help address health inequalities across the population of Thames Valley. So if I just kind of give an overview with regards to the terms of reference and a little bit more context around what the PPG will do, it's worth noting that our terms of reference for this group was co-produced with the support of some of our Alliance patient representatives. It was shared more widely after we held our launch meeting in September, and I've had additional comments back which have now been incorporated into the version that was circulated. With regards to membership and responsibility of members, there's an expectation that those on the PPG will both feed into this group any information of activities undertaken from those kind of support service improvement groups that they're aligned to. There may be representation through internal alliance groups such as our CAGs or wider stakeholder networks, with representatives, as I say, being a conduit to sit on the PPG. I think, you know, with guidance from William as our chair, and also from the Alliance in respect of sort of confidentiality of information being shared, members of the PPG will also have the responsibility for feeding out from the PPG into their wider network groups to ensure that there is an ongoing cycle of communication. Working with William, we're going to establish how best that this cycle of information is achieved, whether or not it's a completion of a sort of a template or perhaps a subgroup meeting of all our patient representatives coming together to share the information about the activities that are currently underway. I think this will help determine content suggestions for future meetings and agenda items for the PPG, and also support the priorities of the Alliance. In the terms of reference that's been shared, we have proposed that the schedule of meetings coincide a month before the quarterly executive board meetings. This allows time for any preparation of items to be taken forward by William to be discussed with Lyndall, also as in support of the executive board panel. Having previously circulated the tour, I'm just wondering if there was any other kind of feedback that people wanted to give now, or whether or not we could take the terms of reference as to be signed off and agreed today.
Okay, are people happy to agree the terms of reference, or does anyone have any pressing point they'd like to make? Happy to agree? Yep, thumbs up. Okay, thanks a lot, everyone.
Thanks, William.
Okay, we are making good time against the agenda, so I'd just like to maybe pause for a few minutes and just we obviously are going through at a reasonable pace, as I was saying earlier, but I think I'd just like to pause for a few minutes and see if there is any kind of pressing points or questions that anyone would like to make. We've probably got 5 or 10 minutes that we can address those. So I mean, we don't have to, but is there anything anyone would particularly want to comment on or ask a question on this stage? If so, show your hand, Martin.
I've made a note in the chat room. If you're missing a representative for the Brain and CNS CAG, I'll volunteer.
Well done. Okay, thank you. Anyone else either want to volunteer or make a comment or ask a question? No? Okay, if not, then we'll just press on then. I hand over to Patrick, who's going to talk.
Actually, I can see Ian's put his hand up,
Ian,
if you wanted to comment. Sorry, William.
I can't see everyone with their hand up. That's the problem. So sorry. Go ahead, Ian.
Yeah, sorry. How do we get into the chat room? Because there's nothing on my menu which allows me to get into the chat room.
Ian, can you see a bubble on the top bar at all? It's like a little conversation bubble. If you click on that, the conversation should appear on the right.
That's the problem. I can't see the bubble.
Okay.
There's always a challenge with IT.
Are you on a Mac or an iPad?
I'm on a Mac.
Yeah, that's probably why.
Well, I mean, I'm on a Mac as well, so it shouldn't, it shouldn't be a problem. But clearly, there's a technical issue behind it, unfortunately.
Patrick, if you click the main screen, you might get a menu bar come up. Has that worked?
Yeah, no, I've tried all that.
Oh wow. Well, I'm really sorry about the IT issues then, but
I think it might be an IT issue. But I mean, rather than sort of waste everybody's time, when the pack circulated after the meeting, I can sort of put in a couple of comments on that. Okay. Is there any comments you want to make now in the absence of being able to write them down, Ian? No, not really. I mean, apart from the fact that obviously haematology is looking for a patient representative, and as a myeloma sufferer, I can put myself forward for that if that's any help. There you go, another volunteer. Great, I love volunteers. Okay, any other points before we move on to Patrick? No? Okay, thanks so much. Patrick, over to you.
Thanks very much, William. Just by means of introduction, I'm the patient public representative on the Thames Valley Cancer Alliance, which also means I represent the Alliance on the NHS Cancer Programme's Patient and Public Voices Forum. And the Patient and Public Voices Forum is very much a link of patient reps from across all the cancer alliances to try to support and monitor the developments going on around the NHS Cancer Plan, which is very much about trying to improve outcomes for patients across England. I got involved over 10 years ago now, following the death of my wife from bowel cancer. It's a sadly classic story. She'd been misdiagnosed a number of occasions, eventually diagnosed very late, which, as many of us know, leads to far fewer options, and sadly she died at a relatively young age of 52. But it did prompt me to try to do whatever I could to try to ensure that as few people as possible went through the same experiences as our family. And I found increasingly that there is a commitment both across charities. I've got heavily involved with Cancer Research UK and the NHS to put patients and the public at the centre of all their developments around cancer. And it links very much to what William and Lyndall were saying earlier. If we're going to get the best outcomes, patient engagement and involvement is crucial. It's very much, to me, I think, about ensuring that whatever we do in terms of developing new provision, improving existing provision, it's very much done with patients and their families and not simply done to them. And I think that's the power of public and patient engagement. It gives us a say. We're the people who use those services. And I think we have far more insights than perhaps we give ourselves credit for. We know what these journeys, as I'd share William's view, I can't think of a better word. We know what these journeys are like. We know the reality of them. We know what we need. We know what we want. And I think the more of us that can get engaged in these activities to help shape future developments, then ultimately the better outcomes there's going to be for patients and their families. So I've been involved with the Cancer Alliance through both the delivery board, which is very much a board that looks at how well that the local alliance is developing the provision in line with the national programme, which is very much about improving access, improving early diagnosis, improving screening programmes, many new developments that Lyndall mentioned earlier, such as the colon capsule endoscopy. And it was all a response to the fact that actually in the UK, our cancer outcomes do lag behind most comparable countries. So there is a national commitment to trying to improve those. And I do believe that we as users of that service, the people who have experience of cancers, we've got that lived experience to bring to these developments, and I think play an important role. Within the Cancer Alliance, I'm also a member of the Rapid Diagnostic Service Steering Group. If we could have the next slide, please. Thank you. And if you're not particularly familiar with the Rapid Diagnostic Service, sometimes called Centre, depending on the local development, there is that excellent link on YouTube, which just gives you a 4-minute explanation of what the services are. But fundamentally, they were launched in 2019, and it's about improving early diagnosis. And I suspect we all know the huge difference early diagnosis can make to the treatment options available and to ultimate survival rates. It's about, I suppose, fundamentally a single point of access for quick diagnosis of patients that have got concerning symptoms. Thames Valley, as Lyndall said earlier, is focusing very much on lung and colorectal symptoms. And already, although they're in a stage of development across the different trusts, already we have had about 1,000 patients through this service in the last 12 months. And it is one of the Alliance's key priorities, as it is one of the NHS's national priorities. Next slide, please. This is just a screenshot of what's known as the Rapid Diagnostic Service Patient Portal. And it's very much an online one-stop shop for patients, where they'll be able to link to what will be known as a named navigator, somebody who will guide them, support them throughout the process from referral right through various diagnoses, through their treatment. And I think, as we all know, the amount of times that perhaps we've had to explain our story to different people, trying to engage different people through the system, this is intended to get over that problem. So as a patient, once you're referred, you'll have a named navigator, you'll have an online setup through this portal to actually help you through and guide you through in the most effective way. It's currently under development, and there is a call out for volunteers, and I've already seen how keen people are to volunteer, but they're looking for a small focus group of people affected by cancer to actually trial it before its final launch. Next slide, please. Again, this is just a screenshot of the patient portal draft sitemap, and this is what the navigator would see. It's not intended as a slide. I appreciate it's difficult to see, but the navigator will see their messages left by the patient. They can be either written messages, they can be voice messages. It will also include a single link to all the templates, all the letters that they've received, to their appointments, and any other background relevant information, sources of support that the patient might want. So I think this is a really exciting development, which should be really supportive of patients through their cancer, their diagnosis, and subsequent treatments. Next slide, please. Just to reiterate, sorry, before we just move on to this, that request, if you are interested in volunteering to actually trial out the patient portal, please give your name to Lisa, who'll be able to pass those on to the developers, and hopefully we'll get a really positive outcome of that for patients. In terms of updates, you can see from that the site-specific pathways, the lung and colorectal services are going live very shortly, either this quarter or early in 2023. They're currently going through the process of recruiting staff and currently mapping all the patients going through and into the new rapid diagnostic service. And the next slide, please. So next steps, you'll see we've mentioned some of them already. The development of the portal continues, and please do get involved in that if you are interested and you possibly can. The recruitment of pathway managers, navigators, developing the IT systems with the technology providers to make sure it's integrated into existing systems, because the whole point of it is to make this so much easier for the patients. I think the rapid diagnostic service is such a positive development for patients. I think it could make a real difference. And I think the more that we as patients, as public, get involved in these developments, the more we can shape them, the more we can really make a difference, make sure more people are diagnosed early, which will ultimately transform lives. It will actually save lives and improve outcomes. So it's a crucial development. I'm proud and privileged to be involved in it, and I hope more and more of us will get involved with all the health developments which will help increase early diagnosis, increase better treatments, develop better treatments, and ultimately improve outcomes for patients. So thanks very much. Back to Lisa.
Okay, just before we move on to the next slide. Good again. I think we've still got a little time because we're doing very well in terms of the time and agenda. So does anyone have any questions or points that they want to make to Patrick or to Lyndall around the RDS?
So I can see Janet's put her hand up first.
Yep, Janet, and then Kath. Janet. Are you there, Janet? Or are you still on mute?
Yeah, sorry about that. Apologies. Okay. I arrived late, so apologies if this has been covered already about asking questions. What I wanted to ask Patrick is there are a lot of people who are not technical, who do not do online. Is there going to be help for such people to actually access? Will they be someone to go through it with them, or will there be instruction? Because quite honestly, that is a real problem. And when people are unwell, they're even less able to cope, whereas normally perhaps they might be able to.
Okay. Yeah. Sorry, it's a good point, Janet, and it has been recognised, and it's about getting more and more people engaged in a way that suits them as much as we possibly can. So the approach to support them through the journey won't be dependent on them accessing the portal. There will be other options offered if patients can't actually do or don't want to. And we're also looking at translation ways so that different languages can be used on the portal as well. But the principle is to make this whole journey through the system as simple and as straightforward and as supported to every individual. The online portal is just one way of doing it. For people who I think increasingly will find that a positive way to do it, but it won't exclude others.
Okay, then fine, thank you.
We've got a couple of other people who want to ask. Kath, you want to come on next?
Yes, thank you. I see the navigator vacancies are going to be a new job within the role of the RDS. Obviously, people like us have lots of knowledge of navigating through lots of treacle at times. Are they going to be professional roles, or are they going to be volunteer roles within the navigator vacancies?
Okay, Patrick, you want to deal with that?
These are professional roles. These are appointments to the trusts.
And I guess I think.
Can I then ask, what type of background will these people have?
I can't honestly answer, because each trust is in the process of putting together job descriptions, job adverts, and so on. So I wouldn't really like to answer for the individual trust, but the principle obviously is that people will have appropriate skills and background to enable them to carry that role out successfully.
Okay, Lyndall, do you want to add anything to that?
Yeah, I was just going to say, well done, Patrick. They are developing job descriptions that will be shared, but it is different for each trust how they're putting that role out. But what we're looking at an alliance is the competency and skill base to do that role and have appropriate training to help the staff. But some of the trusts will have what we call administrative navigators, and others will have clinical navigators. The admin people will always be linking with the senior clinical person. Those people will never make any clinical decision at all, but will provide support for the clinical team in rolling out the RDS pathway. But we are looking at some sort of general cancer training, education, customer service type training to support those roles.
Okay, thanks, Linda. Linda Wilson, Linda, want to come in?
Hello, thank you. I endorse Jan's point that not everyone has access to technology, so some of these advancements won't help them. But I'd also say the portal seems a good idea to me to have questions put in print, typed in, and get answers back in print, because a lot of contact with hospitals is by phoning a number and being called back when there's someone ready to speak to you. And that is harder to keep track of what's been said and to understand the progress. I would ask for more email type or portal type avenues for patients to pursue to get answers and to communicate with their treatment team.
Yeah, Linda,
I think my understanding is that facility is certainly there in the portal, or the planned portal, that you will be able to leave a message, a printed message, you'll get a printed response. And I think there's a principle that I know we've discussed in the development group that's very much about developing an approach that meets the particular needs and desires of the individual patient. So it's trying to cover a way, it's trying to develop a way for each patient that is their preference, if you like, as far as can possibly be done. So that's a principle that's writ large in this patient portal.
Okay, thanks.
Yeah, can I just add to that, just to say, if you're
please.
a patient that likes to talk to somebody, the telephone will still very much be there and your primary source of connecting with the clinical team. If you prefer to have something in writing, the portal will give you that opportunity, and then you'll have a written record there to keep going forward. So trying to adapt to meet, as Patrick has said, everyone's needs in relation to this. No one way is going to be the right way for all patients.
Okay, and then finally, Vicky, do you still want to speak? You've taken your hand down.
Yes, I do actually. Quick question. Well, a quick couple actually. Firstly, who has access to this portal? And secondly, would it be available on the NHS app?
Okay, Patrick, can you answer any of those?
I'm only aware in the most general sense that the data protection around it meets whatever the requirements are. So I think Linda will probably tell you more than I can, but it would be available to those who I think you as a patient want it to be available to, and those who need to have it available. So again, I think it is a secure platform. As far as the NHS, I really can't answer that. I just don't know.
Yeah, this will be a step approach, and there is absolutely strict confidentiality, guidance that we would have to GDPR regulations to follow. This is a first step of Thames Valley having something that's linking in with the current cancer systems within each of the trusts. At the moment, I don't think they're thinking it's linking with the NHS app, but in time, we're taking baby steps at the moment, trying to establish something that's going to work for our local trusts. This will be something that will be, as it's evaluated, people have their experience, will change, going in line with what people actually want.
Okay.
I mean, ideally, yes, being part of the NHS app would be amazing, wouldn't it? So, but let's just try and get something available first and build on it.
Yeah,
Okay.
I think that's a really good point that you make, Lyndall, because the principle behind it is to start small, but to get something online, to get something usable, and then hopefully continue to develop it over time with patients following their responses and their evaluations. So to build it over time, and who knows, as Lyndall says, hopefully one day it maybe everything will be nicely linked together, but we're starting from where we are.
Okay, thanks, Patrick. We've got two more people who want to speak. So, and we're about to hit the time for the next agenda item. So, if you just keep it concise. So, Ray, you want to speak?
Hi there. Yes, thanks. Okay, very quick one. I mean, you probably can't answer this, but I think this is a great initiative, this RDS portal. But I'm just well aware from my own experience that anything that relies on IT development, is a huge risk. Do we know what sort of priority this is getting? Are we happy that it will be progressed in the right sort of time frame?
Okay, Linda, can you address that one?
Yes, I mean, there's a project plan. Patrick's part of it. He's also helping to push this. There is an expectation around delivery and timeframes to do this. Yes, things in the NHS IT is challenging, but as we say, we're starting small and building on this. And there's an absolute willingness across the board to make this happen.
Okay, thanks, Lyndall.
Okay, great, thanks.
Okay, and then finally, Janet.
Yeah, I'm sorry again. Here I am. This may not be the appropriate time to make the comment, but you mentioned, Patrick, you mentioned, well, in fact, and Lyndall as well, that patients will have all sorts of choices. But my question is, will the patients be aware that they've got choices, and will they actually be told? Because sometimes they are taken down a pathway which they're not necessarily comfortable with, and they don't speak up. So I'm very keen to.
Do you want me to cover that, Patrick?
Yes, please, Linda.
Okay, so what we're aware of on Cancer Pathways currently is often you get referred in on a 2-week wait and you have no contact with the system at all, and you're negotiating that until you get diagnosed. Then you'll meet a CNS. The CNS and the support worker will then help support you along the cancer pathway going forward. What we're trying to do with the RDS pathway is to give have someone ready, available, the navigator, to support the person to negotiate their diagnostic pathway. That has been something that's been loud and clear heard that people want from the start, a contact. So that navigator will be introduced when the 2-week wait referral comes in. There'll be information going out to the patient about who their navigator is for the pathway, how to contact them, and the person will proactively contact people and then be that contact point along the pathway until they have a diagnosis. Okay. And then they'll be supported by the nurse specialist going forward. Does that answer it okay?
Absolutely, Janet? Yes. That in theory, that is brilliant, and I'd love to see that that's going to work. And a very good initiative. Thank you.
Okay. Thanks, Lyndall. Thanks, Patrick. And I hope that kind of session of sort of questions has been helpful in taking things forward. Just one final comment from me before we move on. I think one of the things we need to recognise is recruitment. The whole kind of thing about workforce across the NHS, we all know is kind of how challenging it is at the moment. So I think we need to recognise that recruitment for these roles is going to have to fit into that kind of challenge. And, trusts are going to have to be creative about how they approach it if they're going to get the people they need. Okay, moving on then to the next item, Hannah and Natalie going to be looking at an overview of personalised care. We've got about 20 minutes for this, so please let's see if we can get through in that sort of time. Okay, Hannah, over to you.
Great, thanks, William. Yes, afternoon, everyone. So my name's Hannah Hollis. I lead on the personalised care agenda at Thames Valley Cancer Alliance, and I have been fortunate enough to meet some of you on various CAGs and other meetings before. But welcome to everyone who I haven't made contact with yet. Lyndall very kindly gave a bit of an overview previously earlier in the meeting around the personalised care agenda. There's kind of three main elements on the personalised care agenda. So the first is what we would call personalised care and support planning. So this will cover things like the holistic needs assessments that are often offered to patients by their CNS team, the cancer care reviews that should be done in the community by your GP practices, and health and wellbeing events, which hopefully some of you may have been offered in your own journey. The other kind of key elements is that stratified follow-up, which again Lyndall mentioned beforehand. So stratified follow-up is looking at once a patient has finished their course of treatment and they have ongoing tests for a number of years to check reoccurrence of a disease, but also to reassure the patient as well that everything is ticking along fine, is looking at how patients are invited for those tests, how they get the results, how can we minimise the anxiety of that time period, and also what other support do patients need if they're not coming back to the hospital for those tests and investigations. And the third element is something called quality of life, which is what I'm going to be talking to you about today. So I won't cover that just at this moment in time. I will say that the Thames Valley Cancer Alliance website, I've got a section on there for personalised care, and each of these key three elements have got their own page on there. So if you are interested in finding out a little bit more about any of these elements, then please do go and have a look. Once I've finished talking, I'll pop the link in the chat box, and we'll make sure that it's circulated when Lisa sends the slides out in case anyone wants to have a look there. And we have already done it, but just a slight shout out to David as well, who's on the call today. David is our patient representative for this work stream, and he started with us, probably 4 or 5 months ago now, working on this work stream, and that's been absolutely brilliant to have some patient input and feedback. What I wanted to talk to you quickly about today is the Cancer Quality of Life survey. Now, this is something that you may have come across before. It's a survey that's been run by NHS England Improvement and Digital over the last year or two. And they've started surveying patients to find out about their quality of life 18 months after their diagnosis. When the survey was first launched, it started with breast, colorectal and prostate cancer patients. And in October of this year, it rolled out to wider tumour groups. So it's now asking patients with other diagnoses alongside these three. And the survey itself is made up of two particular questionnaires. One measures overall health and one measures the quality of life. And the first data set is now available. So this is data specifically for the breast, prostate and colorectal patients. And so I just wanted to share with you some of the results from the survey today. So if we pop on to the next slide, please, Lisa. So as I mentioned before, there was two particular surveys, two particular questionnaires that were asked during this. And the first one is overall health. And this is widely used across multiple different sites, not just cancer. And it consists of 5 different items, which you'll see on the screen there. And basically, each question had a range of statements, and patients had to measure how they felt on a scale. If we move on to the next slide, please, Lisa. And so when we look at the data combined, we look at what percentage of people that replied reported some level of problem from the Thames Valley footprint. So we had 71.2% of our patients that answered the survey reported some level of problem. And you'll see on the screen here, there's the bar chart, and you'll see hopefully where we've been identified there, you'll see we've kind of popped up in that bluey colour and it says TVCA below. So each of these bars represents a Cancer Alliance footprint in England. And so that's how we can measure ourselves and kind of compare ourselves to how other areas have felt. And we were the only area to fall below that shaded part of the bar graph. And so what that means is that we had the lowest percentage of respondents saying that they had a problem. Now, it's good in some respects because it means that, you know, we can say that it's likely not by chance. We've probably done better than most, or have done better than the other areas. But I will draw you back to the fact that we still have had 71.2% of our patients saying they reported some level of problem. So this is just, I suppose, a comparison against other areas. If we move on to the next slide, what we can then see is we have broken this down between the 3 tumour sites. So it then breaks it down by breast as the first one, and it's got each of those 5 key elements that it asked. And what we actually found for breast was that all of what we asked patients were within the expected average range of what we would expect to see. And obviously you'll see there are some areas where we had a higher percentage. So for example, 70.6% of respondents said that they had some level of pain or discomfort from our breast patients. And some areas we did, you know, slightly better in, I suppose, in the sense that only 12.8% of our patients reported some level of problem with self-care. If we move on to the next one, I believe, is it colorectal next? Yep, that's the one. So colorectal cancers, it's exactly the same format that you'll see as it was for breast a second ago. And what was nice to see about this was that we had 2 of the indicators where we scored better than average here, which means we had a lower percentage comparatively to other alliances for mobility and for self-care. And then the last one that you'll see is prostate. And prostate was the ones where I personally was quite pleased to see these particular results. And that's because for 4 out of the 5 areas, we did score better than average. That's not to say there's not room for improvement. There always is, as we know, but just particularly interesting to see there. If we move on to the next slide, then we'll look at the specific quality of life questionnaire that formed part of the part of the survey. And this was suitable for specifically people who have had cancer. And there was about 30 items on there. And they then summarised that into different categories. So it was then paired up between physical, social, emotional, work and leisure, and cognitive function. And each of the questions asked whether somebody had experienced it in the past week, and if they had, what scale they had. So from a not at all to very much. If we pop on to the next one, the next slide, please. So what we've got here is we've picked out the kind of key areas that stood out to us. And so the first slide here breaks it down, reported work or leisure problems, and it's split by breast, colorectal and prostate. The big figure you see in the circle there is how many people reported an issue. And so for breast, it was 31% reported a moderate problem. For colorectal, we changed how it was measured slightly. So we had 66% of patients reported a slight or no problem related to work or leisure. And for prostate, we had 71% of patients who reported a slight or no problem, which was good to see. And if we go on to the next slide, this is just broken down a little bit more to show you some examples of the data that we've got by prostate. And so it splits into physical, social and emotional problems. And so 84% of our prostate patients said they had slight or no problem with physical problems after their prostate cancer. And you'll see the other figures on the screen there. So if we move on to the next slide, please. Oh, actually, we'll just pop back. The reason that I wanted to share these results with you today is because these results are publicly available, and we have got an even further in-depth breakdown on the Thames Valley Cancer Alliance website, which you are absolutely welcome to go and have a look. I appreciate that obviously if you are a prostate, breast or colorectal cancer patient or carer, you particularly might be interested in your specific tumour groups. The other thing to share is that sort of mid next year, we will have a similar breakdown for the other tumour groups as well that they've started surveying. At the moment, the results are Thames Valley wide, and we are expected to see a hospital trust breakdown, but it won't be until probably April or May time next year. In terms of what we're now doing with these survey results, is it leads us on quite nicely to look at what are we focusing on in the personalised care agenda next year? What's our real kind of key areas that we want to drive forward? And actually, is there anything that we could help to support patients' quality of life? And that could be either at the point of diagnosis through treatment, or it could be actually this is identified that, for example, a year on, breast cancer patients might need a little bit of support at that year post-diagnosis point. And so we're continuing to do further analysis of these results. But like I say, I'll pop the link in the chat box for you, and anyone who wants to go and have a look, please do. You can go and download the full version of this. I appreciate it's a bit of a whistle-stop tour, if you like. I'll hand you over now to Natalie, who's just got a couple of slides. I'll let her introduce herself to you. Just wants to talk to you about a new initiative that we're looking at for health and wellbeing.
Thanks, Hannah. Actually, Lisa, could we pop onto the next slide? I'm going to go straight with just that one. Yeah, lovely, thank you. So, hi everyone. Yeah, I'm Nat. Thanks for having me today. I'm a project manager within TVCA, working with Hannah in personalised care. So I'm going to present briefly the new patient resource that we've been developing over the last few months. I'll give a bit of an overview of the background and then describe where we are currently, and then I'll just quickly outline what we'd like your help with. So really, the original idea for this resource came from one of the trusts. They're basically their response to the lockdown back in March 2020. And they were able to pivot really quickly and begin delivering virtual health and wellbeing sessions online for patients as part of their rehab and prehab service. And this worked really effectively for them, and they had good attendance, and they've carried on using this approach actually alongside their sort of in-person sessions, which have started resuming. But other trusts weren't really able to do quite the same thing for a couple of reasons. So it's very intensive to manage the organising of regular speakers and sort of booking patients onto sessions, and some of the other trusts don't necessarily have the same maturity of rehab and prehab services, so they just didn't have the resource to do it. And even where some of the cancer information centres were sort of attempting virtual events, they just weren't getting patient numbers. So what we decided to do was to have a look at providing this sort of professional, trusted health and wellbeing information, which sort of available as on-demand videos, but produced by experts, and making this available to patients anywhere in Thames Valley. And then this sort of resource actually being available for the cancer nurse teams and health and wellbeing teams, and hopefully general practice as well, to signpost to this as and when it's the right time. And just to be clear, this is as a sort of in addition to anything they're already doing in terms of, delivering in-person or virtual events. So it's absolutely intended as an additional route for people to learn more about these health and wellbeing subjects. We do actually hope to widen this to virtual events, but for the moment we're sort of looking at the resources being sort of on-demand videos. So yeah, where we are currently, really, we've developed a web page that sits on our TVCA website under a new patient section, and we've currently got these 10 videos. We've got talks from a variety of staff, including sort of an oncology physio from Bucks on managing fatigue and activity while on treatment, and a couple of other subjects. We've got a counselling psychologist giving a 3-part talk on psychological well-being and sort of coping with stress around the diagnosis and management of cancer. We've got a clinical nurse specialist talking about what to expect from a holistic needs assessment, which is one of the interventions Hannah mentioned earlier. And we have the lead nurse from Royal Berks talking about COVID and cancer and sort of how to manage against that, the backdrop of what's going on right now. And we're also looking to add dietetic content over the next few days and some more psychological subjects. So we've got sort of plans really for providing really a suite of information that we hope will be a really useful resource for patients. So where we are at the moment, we've got our initial version of this resource, and we'd really like to circulate this amongst our members of the PPG and gather some feedback. Really, we've got a structured survey that is just intended really to give you a sort of an idea of those aspects that we know we need to ask, and really just to understand your thoughts on the webpage as a whole, how the information's presented, as well as feedback on that specific content in the videos, just really to get those insights that you will have as experts in what you need. And yeah, so really just to get your feedback on whether this is a resource that you would use and recommend. So yeah, as I say, there's a survey that is in development, or that's being developed, but I'd also, be really happy to receive feedback verbally on it. So that's an option for anyone who would like to do that. So yeah, really what I'd like to do is circulate this resource with a briefing in the next couple of weeks, and it would be great to have the support of as many people within the PPG as we can, really giving us feedback on this. And we want to really shape this based on your thoughts. So we hope this provides a bit of a starting point for that. And I think in terms of sort of wider patient involvement, really we're going to be trying to use that feedback, those feedback channels, the YouTube feedback and those sorts of channels to respond to the subjects that patients are telling us they need and want. Based on whether things that we do know, things that we don't know. There might be subjects that we really have just not considered that you might want to be hearing about. So yeah, that was a bit of a whistle stop, but thanks for your time, and yeah, really happy to take questions and comments, and otherwise I'll be sharing the resource via Lisa in the next few days.
Brilliant.
Okay, thanks both. Let's take a few minutes. I mean, again, I think we need to press on, but I think it's important for people to have the opportunity if there are any pressing questions that can't be dealt with afterwards. So does anyone have a particular question they want to raise? Yes, Vicky?
Well, I was just going to say this is a great resource, and it will be really useful to share with members of our cancer support network. So no, it's brilliant, great resource.
Okay,
thanks, Vicky.
Anyone else want to comment or question? No? Okay, well that's great. Thanks very much for that comprehensive presentation, and great that you were able to stick to time. You've always been practicing.
I have.
Okay, let's sort of move on then to looking at sort of just wrapping up and looking at sort of future admin. I think it's really important that we're able to plan meetings in advance, and sort of so what I'd like us to be able to do is to kind of agree a schedule for the rest of the year. I'll say a bit more about the timing of that at the moment. But I think that's really important for all of us to, in order to kind of plan around our busy lives. I think it's also particularly important for Patrick, Lisa and I to be able to prepare, because again, I think what's really important is that all of us have the opportunity to input into the agenda, and it's not just the three of us who are sort of saying this is what we think is important. Clearly, there will always be time limits, and I'd have to be making decisions about what to prioritise. But I think the starting point is to ensure that everyone has the opportunity to input into the agenda setting. So we're talking about quarterly meetings. Can we just move on to the next slide, please? You'll see on the right-hand side, sorry, you see on the left-hand side what the broader schedule is for the organisation on the left-hand side, and then on the right-hand side with letters in red, what we're proposing in terms of the PPG. So that the dates on the left-hand side there, the next one in March, and then going across, you'll see the timetable we're talking about in terms of the call for papers, and then the kind of the deadlines that we're talking about in terms of moving on. So I think it's important that we do have a final deadline for papers, and therefore we can make sure that we get them out as far in advance as possible, so that people have the chance of kind of reading, studying them and absorbing them. So can I just pause there and check, are people happy with this kind of overall approach in terms of planning organisation? Does it make sense?
Yeah.
Okay. Well, again, these dates will be circulated and they'll be part of the pack. So, but if you want to, scribble them down, please feel free. So before we wrap up, and we're well ahead of time, so we do have some time for further discussion. Is there anything in terms of additional items that people want to raise that we haven't covered on the agenda that are pressing? Any questions or points that we may not be able to answer today, but people want to sort of say something about? Anyone? Yes, Kath.
Going back to the personalised care process through the holistic needs and onto the quality of life surveys, what data does anybody have at the moment over whether that's working, that process? Right. Because my husband, so I'm the carer of my husband, and he was diagnosed in 2018. So it's a few years ago now, but that process for us did not work at all. Right. And so the steps that you actually mentioned did not happen. Right. And I'm very intrigued, are they happening, or is it you want them to happen like that? Because it's great having a system, but it's knowing that it works. Because the holistic needs came at the completely wrong time for my husband, and nobody has ever done quality of life survey on him because he's a blood cancer patient. So I think it's great having the system, but how are we going to monitor it, or are we monitoring it currently? That may be something for another meeting, but I value your comments or thoughts on it, please. Thank you.
Hannah, can you briefly comment on that, please?
Yeah, of course. Thank you, William. Thanks, Kathy. That's a great question. In all honesty, if we're being totally honest, it's in development as opposed to being fully rolled out. All of our trusts are now offering patients at least one holistic needs assessment, and the national guidance on it is that patients should have a holistic needs assessment around the time of diagnosis and around the time of end of treatment. But obviously there are certain tumour groups that perhaps isn't the most specific time for, and we do encourage our hospital colleagues, and I know our CNS colleagues want to do it at the time that's most appropriate and most beneficial for the patient. Otherwise, it's not a good use of everyone's time, is it? So we are still working with all of the hospitals across the Thames Valley footprint to really roll out that second holistic needs assessment, and also to then get that information transfer over to primary care as well, to your GP practice. Because a lot of the time what happens, and I think it was mentioned again by Patrick maybe earlier in the call, is that you end up relaying the same information and the same story to multiple different healthcare professionals. So for us, it's about having interventions at the right time, at the most useful point for the patient, but then also making sure that that information is then transferred out. And our colleagues in the hospitals are doing extremely well and are working extremely hard on the agenda already, but we have identified areas for improvement. And like everything, like Lyndall was saying, with the cancer waiting times and the targets, we have the same kind of monitoring in place where we can look at what percentage of patients are having holistic needs assessments done, are having the end of treatment summaries, and we can also now, as of next year, sort of as of 2022 January time, we'll be able to see the point in the pathway at which patients are typically having those holistic needs assessments as well. But I personally, I'm not a nurse myself, but kind of speaking on behalf of our CNS colleagues across all of the trusts, I absolutely know undoubtedly that they would want to do it at the point at which it's most beneficial for the patient. But unfortunately, there are, like always, barriers to some of those things being delivered. But yes, I appreciate, Kath, this probably is something we've been pushing slightly more in the last couple of years. So perhaps for yourself, it may have just been that I think, was it your husband, sorry, that you said, Kath, was just a little bit early, I suppose, on some of this agenda.
Okay, thanks.
Sorry, and just one quick other question is the monitoring, you're monitoring quality of life, but are you monitoring consequences of treatment? Because when when somebody has chemotherapy, it can do lots of damage, as we all know. So it may be that they then have to be referred to another discipline within the hospital, which is what's happened to my husband. And it's almost, there needs to be a little bit more empathy and compassion, I think, over when you are referred through to another discipline, because there doesn't appear to be a great deal of understanding. So he was referred to rheumatology because he's got peripheral neuropathy. And I think that it's that element of it that there needs to be a lot more support to people who've been damaged by the treatment. They're alive, but they're damaged by it. And I think there doesn't appear to be very much empathy with regard to that. I don't know how you solve that, but I think it needs to be put in the mixing pot. Quality of life is fine.
Yeah.
Yeah.
No,
Can I? Oh, sorry.
Yeah, sorry. Quality of life is fine, and you're gauging it against the rest of the country. But for those 30% of people in one of those categories that are having a horrible time, there needs to be some more data done on that 30%. If you see what I mean.
Kath, I think you're right, and this is a broader question. But if I can just ask Lyndall, if there's a brief comment you want to make on it, Lyndall, please.
You know, I do. I very much hear what you're saying, Kath, in relation to the consequences of living with those side effects of treatment. And it is something that is known about. And certainly in sort of cancer reform strategy or the sort of NHS long-term plan, understanding those consequences is really important. Now, I think, as Hannah has sort of said, different trusts are in different stages of evolving and how they're supporting patients to live well and beyond. In some places, there are late effects clinics. Now, that's not in place for all services, but you know, I think what we can say is we note your comments. You know, we are working with the national initiatives. I think it's great that we've now got a quality of life survey. This has only started, you know, in the last couple of years that the NHS England or Department of Health have recognised that importance. And so I think what I have to say, this is a journey and we're evolving and trying to improve the services. But you're right, we need to, I'd like to think, as people do holistic needs assessments at the appropriate time, these things will be picked up and appropriate follow-up care and support where there's individual needs are being picked up, because we know a one-size-fits-all follow-up protocol doesn't suit, but we need to tailor it to people's needs. And that's where the HNA will hopefully support, and the clinical teams on the ground will then support those specific needs. But long-term effect clinics are things that we're sort of aware of, let's say, and we'll try and look at how we support that going forward.
Okay, thanks, Lyndall. Again, I think this is something that we're probably going to have to come back to, but let's just sort of stop our conversation for now. Before we wrap up, can I just ask just a couple of people if any final things they want to say? Lyndall, any sort of final points you want to add before we wrap up on anything?
I just think it's been great conversation. Thank you for joining and participating in all of this. This is exactly what we want, is the right sort of questioning and asking us and us understanding priorities. So thank you for your engagement today.
Okay, and Patrick, are you still with us?
I think Patrick had to leave for another call.
Yeah, he thought he might. And Lisa, any final comments or things you want
to reiterate, really, thank you ever so much for everyone joining today, and I look forward to anybody who wants to come forward to obviously help with the RDS patient portal. By all means, please sort of send me an email, and with regards to obviously Martin and Ian, I have actually already kind of suggested that you might want to belong to our clinical advisory groups, to our leads. So that's brilliant that I can now sort of push that a little bit further for the leads to engage more with you. So thank you.
Okay, well, thanks everyone. Just a final point on the admin. In terms of meetings, I think what we're going to try to do is potentially schedule a maximum of 2 hours. Now, clearly we may not need 2 hours, but I think it's probably helpful going forward that we have you know, marked out in our diaries what the maximum might be. So I hope that's going to be suitable for people. So let me just reiterate the thanks for everyone for joining. You certainly made my first meeting a pleasure. And as I said at the beginning, I hope as we go forward, this can be much more interactive than we've been able to make it today. So thanks everyone. Enjoy the rest of your day.